We'll get started. Hello, everyone, and welcome to today's webinar on capturing cost data. This is the 5th webinar in the 6-part Evaluation Fundamentals series, and this is brought to you by the AIM Local Health Project. This is a research project out of the Prevention Research Center at Washington University in St. Louis, and it's funded by the National Institutes of Health. Hi, I'm Renee Parks, the project manager for AIM Local Health, and the host for today's webinar. Like our previous webinars, this one will be recorded and you will receive an email the next day on where you can access the recording and the slides. Okay, so we're making our way through this series. We're at number 5 and we have one more webinar left that will be in 2 weeks, and it will cover the utilization and dissemination of our evaluation results. Our webinar series was developed by the Prevention Research Center in partnership with the Evaluation Center here at the Brown School at Washington University, and with support from Research and Evaluation at NACCHO. And of course, the goal really is to equip you with enhanced skills and confidence to develop or enhance your program's evaluation plans. So just a note about the evaluation plan technical assistance, that is currently going on right now. We're accepting those requests, and the requests can include guidance with your process and outcome objectives, as well as those indicators, fine-tuning your program's logic model, possibly data collection methods, and a plan for that, as well as maybe supporting your dissemination plan. So it could be covering a couple of those elements. And the evaluation technical assistant consultants would either be the Brown School Evaluation Center, our team at NACCHO from Research and Evaluation, or the PRC. And just a note, there really is no limit on how many programs from your local health departments submit requests and receive requests. We just need you to submit your requests by the deadline. And our deadline is coming up. It's next Friday, October 11th. And we really don't want you to miss out on this opportunity, okay? So submit those requests and we will triage and get you supported with some evaluation to occur, I don't know, anytime between late October through the end of the project in February of 2020. Okay, so I want to just highlight some of Zoom's settings just for our new friends, as well as reacquaint our friends who are returning. So as you all know, you can adjust your audio settings by looking in the lower left-hand corner of your Zoom window, excuse me, so you can adjust those there. As you go across and you look at the bottom middle, you can see that there's the chat function, which we'll use, the raise hand feature, so you can alert, call attention to yourself. We also like to use this feature to get a show of hands. So the raise hand feature is right there, and then Q&A. So please submit questions and comments throughout this webinar. We will address them throughout. And then you can adjust your Zoom window by looking right at the top at the view options, original size or exit full screen. Okay, I'd like to introduce today's presenter, Karsten Baumann. We're so pleased that he's with us today. He serves as the manager for maternal and child health epidemiology and evaluation programs for early childhood, and the external evaluations for the Colorado Department of Public Health and Environment. He also teaches and consults on economic evaluation nationally. Karsten has more than 25 years of experience in applied social science research. He is primarily responsible for the design and implementation of an overall plan for measuring the effectiveness of the state tobacco control program, as well as the maternal, infant, and early childhood home visiting program. He also leads the quality improvement and evaluation for Colorado's early childhood programs. He provides consultation to other states, foundations, and the Center Centers for Disease Control and Prevention on evaluations of systems change, tobacco control, physical activity, and nutrition interventions. So with that, I'm going to turn off my video and let Karsten take it away.
All right. Hello, and thank you for joining me today. I know economic evaluation is maybe not everybody's favorite topic. It happens to be one of my favorite topics, even though you can tell by Renee's introduction that is not my day job. I am not Colorado's health economist, but in a former life, I used to work as an economist for one of the regional banks. And so occasionally now I get to practice what I as well as in life before joining public health. And Renee, am I able to take control here? Am I able to share my slides?
I'm going to stop sharing the slides that I have, and then you can go ahead and if you would like
take
share.
Over. All right. I am not seeing the share control here.
It might be on the bottom.
Bottom. Oh, thank you. All right, here we go. As I said, I'm not the department's economist, but I have been fortunate enough to teach economic evaluation across the country for a few state health departments as well as local agencies, and this is a little bit of a different take on that. So I've heard that several of you have participated in the broader evidence-based public health course where you may have gone through this full module, but after teaching that course, we realized there's a lot more that needs to happen in terms of maybe making it more real in terms of what we all might do when we get back to our desks. And the first step of any sort of economic evaluation is being able to identify the cost. So that's what we're going to focus on today. And here is the evaluation process wheel that we've been using for this entire series. So it's based on CDC's evaluation framework. And economic evaluation can actually fit in pretty much anywhere around this circle here, that it helps us focus our evaluation. It helps us figure out what kind of data we want to collect or need to collect. It will describe towards the end of the webinar a little bit about what data collection looks like when it comes to cost data, and then analyzing and interpreting those data. I'd say that it even fits into these pieces here in terms of recommendations, in terms of costs, and describing the program in terms of costs instead of just what are the services delivered or the interventions that are being done. So the goals for today's webinar is, one, we're going to go back and for those of us that have participated in the broader evidence-based public health course, we're going to review some of the key evaluation concepts. For those of you that did not have that opportunity to participate in that, it'll be a preview of those concepts. Then we'll talk a little bit about how to identify cost data and be able to capture that for an intervention or program. And then in the third section, we'll talk about developing and implementing a cost tracking system. So again, this is our agenda for the day, basically what I just said in terms of the goals. So let's dive right in with the first part. So in this first part, what I want to address are these 4 questions that will help make the other parts around costing more relevant. So first of all, defining economic evaluation, describing the different types, whose costs and whose benefits are we talking about? That puts some parameters around what we're going to capture. And then finally, what are some possible outcomes of an economic evaluation? How are those presented? So let's jump right in. So the definition of an economic evaluation is that it's a systematic process or a framework to compare the costs and outcomes of alternative interventions to inform decisions about scarce resources. So bottom line is that it always involves at least 2 different interventions. So you can see here in the definition that it talks about alternative interventions. Well, we might say that, we're not currently doing anything to address tobacco use, for example. In that case, the alternative intervention that we're comparing are programmed to is the status quo of not doing anything else. So in terms of a cost perspective, the cost of the status quo to our individual agency might be zero. And then when we implement a new intervention, we suddenly have a cost associated with that. Something to keep in mind that economic evaluation is a helpful decision-making tool in terms of potentially prioritizing by cost. So, we might pick the intervention that's most cost effective. So we'll talk a little bit more about what cost effectiveness means, but basically it lets us go through this analysis process and figure out which intervention has the biggest bang for the buck. Where are we getting the most health benefit? The downside of economic evaluation, it does not help us identify what the right allocation of resources is. It's not a magic tool that says, here's the one thing that we should do, or here are the two things we should invest in across public health. Because the thing that economic evaluation does not consider are issues of equity. So it's strictly concerned about efficiencies. Are resources being allocated in the most efficient way, which is not always the case, which doesn't always align with the most equitable distribution of resources. So just one of the limitations of economic evaluation. So this chart here, this table summarizes the 4 main flavors of economic evaluation that we encounter in public health. There are, of course, many other subtypes, specialties within this. So the way this table is organized, in the left-hand column, it has the name of the type of economic analysis. Then a little icon, and this came out of the folks in the diabetes prevention program here, had to sit through one of my presentations and gave me some critical feedback about how boring my presentations are. So they told me I needed to flash it up a bit, and so I came up with these icons. So this is the best I could do to make it a little more entertaining. The icons are a quick summary of what concept is trying to be described here. The next column describes the benefits or the outcomes that are measured to do this type of economic evaluation, and then how the measurement of benefits or outcomes occurs is in that last column. So let's step through these really quickly. And one thing to note here, as we go from the top to the bottom, we have more diverse programs that are able to be compared, and I'll come back to that point as we finish up the table. So the first type is cost minimization analysis, and the icon here is from moving from $2 signs to $1 sign, where we would be looking at comparing 2 different interventions that produce the same exact outcome, the same number, the same type of outcome, and we're trying to answer the question of, can we do it for less? A non-public health example of that would be going to the drugstore. You're looking for some relief from that, for a headache that was caused by sitting on a webinar on economic evaluation, and you see there's the name brand Tylenol, and then there's the store brand acetaminophen, same active ingredient, same dose, same effectiveness for curing your headache, and the store brand is probably going to cost less. So that's a basic example of cost minimization. Cost effectiveness here, you can see actually, it looks like one of my icons fell off. I apologize. There's supposed to be a non-smoking symbol on the other side of the scale. So on the one side, you have dollar signs, that's the cost. On here, it was supposed to have a little icon for not smoking. So the effectiveness is a single health outcome. And the question this type of analysis answers is whether the natural outcome is worth the cost. So natural outcomes are things like extended life years or a change in behavior, like no longer smoking, or it could be something like a clinical measure, like a reduction in A1C levels or a reduction in body mass index. So it's the cost on the one hand, and then the natural health effect outcome on the other side of that scale. Cost utility analysis is a subtype. It's a specific type of standardized outcome. And here, the utilities are a made-up measure that economists have come up with to essentially measure happiness or well-being. So it's a standardization mechanism. And so any type of health improvement is taken back to a standardized scale. It's probably a little more complex than we need to get into here today. I think there are entire courses taught on cost utility analysis, but I just wanted everyone to be familiar with that. And the question that it answers is whether the costs are worth the quality adjusted life years that come out as a result, as a benefit of that intervention. So therefore, dollar signs on one side and happy face on the other. Cost benefit analysis is probably what most people have in mind when they ask for an economic evaluation of our interventions or programs. And what that does in terms of the analysis, we have costs on one side, but now the outcomes are also converted to dollars, so that we have dollars on both sides of the scale. And a subtype of this type of evaluation is the return on investment. So is there a reasonable return on investment is one of the questions that helps us answer. And reasonable return doesn't always mean that it has to be, that you have to recover the full amount of the investment. And I would actually say that for most public health or human services or social services interventions, getting a return in excess of the investment is probably not a fair standard to have, since most of these services are safety net type of interventions. But there are a few exceptions where if we invested in broad smoking cessation, for example, or diabetes prevention, it would probably pay for itself in terms of the state Medicaid office saving money in terms of future costs not incurred. And that's just a quick review of the different types of economic evaluation. And as I said, as we go down the list, we can compare more interventions. And that's because with this very last one, cost benefit analysis, we're comparing all the outcomes in dollar terms. So we can look at outcomes from criminal justice to public health to human services to behavioral health, because we're converting all the outcomes regardless of where these outcomes occur in dollar terms. One of the key concepts in economic evaluation is the need to define the perspective of the study, of the intervention. And the perspective can be very narrow or can be very broad. And you can see down below, I've tried to illustrate that with the narrowest of perspectives is that of the individual. So we're looking at what is the cost of a certain behavior to an individual, but then also what is the outcome for that individual. The broadest, and there's a circle around this because one of the other economists I've partnered with in developing some of these materials, her perspective is that in public health, everything should be from the societal perspective, because we're looking at the costs and the outcomes broadly across state agencies, for the public at large, employers along the way, and trying to capture everything. My perspective is that for most cases, in terms of me working with programs, it's been that of payer or government. What we want to know is, what are the costs to my program? So if I'm running the diabetes program in my local public health agencies, what's the cost to me for offering a diabetes prevention program? And then on the other side of the scale, what's the return on that investment in diabetes prevention? In most cases, that return actually accrues to our state Medicaid office, because they might be covering the medical services for people with diabetes that are also being potentially reached by our interventions. It could also be somewhat narrower in terms of a group, or this could be defined as an employer or a provider group in terms of what are their costs, and then what do they see as an outcome in return.
Karsten, sorry to interrupt. There was a question related to the previous slide, kind of referring to the cost utility analysis. If we can measure years of life gain, is it possible, or why can't we have a measurement of racial or health equity gain, like the number of are more vulnerable populations who gain years of life or quality of life.
Wow, we should do a separate webinar on that because I love that question. It's a very interesting point that in the strict sense, there really is no way for the math in terms of the equity difference being improved. You know, what is the economic benefit of that? It's a separate, but you know, that being said, I think that's one of the considerations that needs to be brought in mind. I think the reduction in health inequity is a goal in and of itself beyond just the extension of life years. I mean, another way to look at it, and you know, maybe this was embedded in the question, is increasing life years for those that were maybe at the most inequitable, at the lowest range of it, would be a potential improvement. Yet, if we're doing our study broadly across populations, there would be no way to quantify what that gain is just for that one population. I hope that answers the question somewhat.
I think so.
Okay.
Yeah, it's a good question, really good question.
Yeah, so again, you know, economic evaluation is just one tool, and we also need to keep our eye on how does it affect equity, because, you know, as I said before, sometimes it's cheapest for us to deliver our programs or services to those that are already easily reached, in which case we would actually increase the inequities. So providing services to those that are maybe difficult to reach or underserved would, you know, by not focusing on those populations, we're increasing the gap, and focusing on those underserved populations may actually cost more and drive up some of our costs. All right, so perspective matters in terms of which agency we want to answer the questions for, whether it's, you know, from the individual on up to societal level. That sets the parameters around which costs and which benefits we want to capture. Just one quick point to illustrate this is an individual who's fully insured might not care that, you know, their addiction to tobacco can potentially lead to lung cancer, which has a high medical cost to treat if they don't have to actually pay for that cost, so they're fully covered. But what might matter to that individual is to illustrate that by stopping the use of cigarettes, they can actually save a certain amount of dollars by the cigarettes that they're no longer purchasing each day and over the course of the year, so that the costs that might matter more to that individual are those for the expenditures on tobacco. All right, so here are just some examples of, depending on perspective, some of the costs that might be incurred. So I actually just talked about the individual, the tobacco example, but there could be other costs that might be incurred by an individual. So through our public health programs, some years ago, were offering free access to colorectal cancer screenings. That does not mean that free also meant there was no cost to the individual, because the individuals still had to find transportation to come to the clinic. They had to take time off of work for their exams, and maybe the day before for their bowel prep. If they had children, they may have needed to find childcare for their children while they were going through the procedure. So just an example of some costs there. But those weren't costs that our program, our colorectal cancer screening program, bore, because they did not reimburse individuals for their time, for their transportation, or for their childcare. So instead, looking at a program or agency perspective, the colorectal program had costs that were associated with the personnel that ran that program, the rent and utilities that they needed in terms of having office space. They probably had some overhead costs, as well as some media, whether that's media in terms of advertising through radio, television, billboards to make people aware of the program, or whether that was outreach to the provider networks. So those are very different costs than for the individual. Employers might have costs in programs, and sometimes we use these costs as a way to encourage providers to expand coverage. For example, we've worked with self-insured employers, including our state-owned state personnel system, to increase the coverage for diabetes self-management education, because by reducing those diabetes-related costs, insurance premiums can actually go down. There's also another thing that speaks to employers about costs or lost productivity, so that people not coming into work because they're ill or they have doctor's appointments, or if it's people taking smoking breaks can add up to an employer, as well as the effects of staff turnover if people are unhealthy to the degree that they have to leave their positions, and the cost to the employer in terms of replacing that person. Insurers, for example, the state Medicaid office has costs that are related to services and supplies, as well as, on the flip side, the cost savings associated with a reduction in demand for those services. And societal takes into account all the costs, all the way from the top of the table down. So this is really one of the most complex types of economic evaluation or cost analysis to do, the societal level. In most cases, we're going to be either here at the program level or at the insurer level, and sometimes also the employer level. Possible outcomes of an economic evaluation can be summarized by this 4-quadrant matrix. And just in your chat box, where do you think would be the ideal place to be in terms of outcomes? Go ahead and write your answer into the chat box. So quadrant 1, 2, 3, or 4.
No one's responding.
Nobody's responding? Did everybody go to sleep, or? Normally I do these presentations after lunch, and then I feel like a magician or a hypnotist that people doze off as I'm presenting on economic evaluation.
I got some 3s and I've got some 4s.
Okay. So the ideal is really, we would want to be, oops, see if I can go back. There we go. The ideal would be if we have an intervention or program that saves us money and people are better off in terms of their health, that is the perfect place to be. So what's the flip side of it? So those of you that are willing to type into the chat box, where do we absolutely not want to be?
2.
Absolutely right, because I mean that would be a terrible situation. We have limited resources, and now we're spending more money on an intervention, and actually people's health is worse off. The reality is, most of the time when we're making decisions about public health programs, is that we're often in quadrant 1 or 3. And neither of these are necessarily bad on their own. We have to consider some of these other factors. So health equity could be one of them. It could be the reach of our program. So an example that I've come up with is quadrant 3, we're saving money, but maybe we're worsening health. This is a conversation I had again with our colorectal cancer screening program, that the gold standard in terms of care is colonoscopies, but those are expensive. You know, on the order of, I'm going to pull a number out of the air here. Let's call them $1,000. Well, or actually for easier math, let's call it $3,000. An alternative is the FIP test, the blood stool test, and that costs about $30 per person. So by switching which type of intervention we're promoting, we can substantially reach a lot more people. So we can reach 100 times more people with a blood test than we can with a full-blown colonoscopy. So it saves us money, or it allows us to have expanded reach because it saved us money per individual. Does it worsen health? Maybe, because if somebody has a positive finding with the colonoscopy, the polyps can be addressed right there on the spot, versus for the FIP test, they'd have to go up for a follow-up procedure. So that's just one example, and we'd have to weigh, are we screening the right people using the more intensive, the colonoscopy, versus maybe those that are at less risk, we're using the less resource-intensive approach to screen people. So again, this is just what comes out as a result of that comparison of, remember, it's two types. You're comparing a new intervention either to the status quo or to another intervention, and we find that it either saves us money, costs more money, and then it has an effect on health. So that was just the quick review of economic evaluation, and if you'd like more on that, I encourage you to participate in the broad evidence-based public health course. But let's dive right into what the main topic of this webinar is, and that is the different types of costs and economic evaluation. So we'll treat these questions in turn, which cost to measure. We'll get in the differences between direct and indirect costs and where we might be able to find documentation of these different types of costs. So here's a quick decision tree to help us walk through. This is actually also a helpful diagram if you decide to go down this path of doing your own cost analysis or beginning a broader economic evaluation. The first question is, can we find the costs in the literature? I would always suggest, before doing an evaluation on your own or an economic evaluation on your own, see what you can find in the literature. And if we can find the cost data in the literature, that's often good enough to answer questions that people, whether it's legislators or the general public, might have about our interventions. We can find those in the literature and use those costs. We might have to make some adjustments in terms of inflation, depending how long ago those costs were documented. But if we can't find it in the literature, then we need to figure out, are we starting a new program, or is this a well-established program? If it's a new program, we'll have higher costs because we'd have to also document the development costs, the research and development, the more intensive evaluation that goes into it, as well as staff costs, and maybe even some software development to help us track outcomes or the implementation of the project. If it's a well-established program where we know what we're doing it consistently, then that's a little more straightforward. We would then have to create mechanisms to document the costs of the program, the direct costs and the indirect costs. So let's define direct costs. Direct costs are defined as the value of resources used for program implementation paid by your agency. These are also known as the financial or budget costs. So how I imagine many of you have had to do budgets. And would you say that your budget covers the entire cost of the intervention or program you're implementing? You can feel free to express your opinion in the chat box or just think of your response. I find that in most cases, the budgets, whether we get our funding from a foundation or from the state or from federal funders, don't actually cover the costs. We have ways to blend or braid funding to help cover some of the things that a budget request might not cover. So we go a little bit further in economics that we define costs as variable costs or fixed costs. Anybody have an idea of what a variable cost is? Can you, are you willing to share in chat what that might mean? Is it quiet, Renee? Actually, I can't see the chat box while I've got my slides pulled up.
It's quiet right now. There's been good buzz for previous, but I would think the keyword would be variable.
Right.
Mm-hmm.
Well, I'm not going to keep you in too much suspense. So it is costs that vary based on a number of participants. And I'll have you think of some examples here on the next slide. But let's talk about fixed costs. Fixed costs are those that do not change with the number of participants. So sometimes we can enroll more people in our program, and some costs will not be affected at all, like whether we're serving 10 people or whether we're serving 50 or 100 people. Those are the fixed costs. So anybody want to humor me with some examples of variable costs? And at the same time, if you can think of examples of fixed costs, you can enter those in the chat box. While you contemplate that, I'll have a sip of my tea.
Come on, everybody. Hang in there. Let's see. Supplies would be variable. Rent would be fixed.
There you go.
Fuel would be variable.
Yes.
Nice
Thanks
work.
for playing, Renee. I appreciate it.
Oh, these are from the group. This is from group.
Oh, from the group. Okay.
Yeah.
I can't see the chat box. So
yeah, no,
excellent.
I'm sorry. I'm just relaying the group this time.
Thank you.
Utilities would be fixed. Salary fixed. Right?
Salary's fixed. I wish we got more money with the more people we serve. Wouldn't that be a great incentive?
Yeah.
So variable cost. It's kind of interesting that labor is usually fixed within a given year, right? I mean, one, we often can't even do cost of living increases, and our budgets are submitted well in advance. So labor, we're usually kind of stuck with whatever budget we set for ourselves, whether we expand our program or not. However, if in some cases, we might not need to hire additional staff to meet the increased demand for our services. Say we're offering tobacco cessation services, and we're providing those classes in the community, and now we have a great demand for it. Now we have to hire 5 additional cessation counselors to meet that demand. In that case, it would be a variable cost, but a lot of times it's not fixed. Supplies might be, so whether those are training materials or testing equipment, so those things vary with the number of participants. And fixed costs are usually things like what shows up as that indirect line where we're paying for our agency's leadership, so the management of the agency, the equipment. We usually don't pay more for our phones and copy equipment just because we've expanded our program. Same thing with rent. That's usually fixed, as are the utilities. So indirect costs. I imagine many of us have had to work on budgets, and there's that term that you usually see. It's usually that second to the last line on a budget that says indirect, and it's a percentage, right? So forget that. Economists have a different definition for indirect. It's not a percentage or a rate that goes on the bottom line to cover all those things that weren't itemized in the budget. Our definition in terms of cost analysis is the value of resources used for program implementation paid by people outside of your agency. Another way that this shows up in the literature and conversations is that these are the opportunity costs or economic costs compared to the financial costs that we were talking about before, the direct costs. So let's think about some examples of these indirect costs. So I already gave one example of cost to participants. Can you think of some other ways that a participant might have a cost to be part of one of our programs or interventions that we're offering for free? That is, we're not requiring any sort of co-payment.
I'm going to give a moment. We've got some really good input. Travel, yeah, transportation, great. That's from an attendee.
Absolutely. And what about examples of costs to outside parties?
Time.
So not the participant. So let's go back to
volunteer time.
Volunteer, absolutely. That's usually one of the main things that we rely on, right, in our interventions.
Federal government payments, would that fall there?
It potentially could be, if that's not part of our budget, or it could be one of the advocacy organizations. So, the local diabetes association, for example, might be contributing to the success of our intervention. And it could take many different forms. So I just put up the answers here. So for participants, it's time. So time participating right now, this webinar was free to you, but it's not actually free to you because you're giving your time that you could be doing something else with. And so in that sense, it's a cost to you to participate in this webinar. Travel, in some cases though, you see the little asterisks there. Sometimes programs have built, especially in addressing disparities, have built in travel vouchers to make sure that those that are most vulnerable can participate in the programs if it involves travel. It could be equipment, whether that's tennis shoes that the person needs to buy to participate in a physical activity, or a blood pressure cuff to monitor their blood pressure daily. It could also be side effects to any sort of participation, but that's luckily fairly rare in public health. Outside parties, volunteer time is the main thing. It could also be in-kind donations such as space, equipment, expertise. Sometimes organizations partner with advertising agencies or other creative types to help create flyers or newsletters to get the word out. And it could be caregiver time. So whether it's somebody bringing the participant to our events, to our programs, or whether it's taking care of the children while that person participates. So those are indirect costs that we would also want to capture if they're necessary for participating in our program. So let's go down the rabbit hole here. Here is one of the tougher costs to include, and there's no absolute rule in terms of needing to capture them, but it's often good practice if we can document them without too much effort. These are averted costs. So averted productivity losses, I would say this matters most to capture if we're working with employers, trying to encourage an employer to increase a benefit wellness program or coverage for certain health services like diabetes self-management education or diabetes prevention programming or tobacco cessation programming. We would want to be able to document for that employer, or with the help of the employer, the averted productivity losses. So those are losses that the employer incurs. It doesn't affect our program if somebody's working for the public school district and we're sitting in public health, if the person at the public school district is missing days off of work, right? But it matters to the public health agency. Or if we're working with a manufacturer, the people not going to their manufacturing job doesn't affect us, but it does affect that employer. And so that would be the value of avoided sick days and reduced presenteeism. So presenteeism is just people showing up to work, they may be feeling ill, not feeling quite right, and they're not as productive as they would be if they were healthy. So if we can quantify those in terms of how many hours does that amount to in a given month or year, and what's the salary range of the employees that are missing time, that would be a way to quantify those productivity losses. Averted treatment costs are on the healthcare side. So again, where that matters to capture is if an employer is self-insured, that is by their employees using more of the healthcare resources, it drives up the cost, the premiums of the health insurance. So that's where that matters the most. Or in working with our state Medicaid office, if we're trying to encourage Medicaid on the one hand to expand a program, a prevention program, we'd have to be able to say, and it will reduce your cost outlays for treatment down the line. So the definition is that it's the value of health care related expenses avoided due to better health. Note though that we're technically talking about a benefit or an outcome of the intervention. However, in terms of the math in economic evaluation and in cost analysis, it's actually treated as a negative cost. So if we had higher negative costs than our original program, then we actually would be making money, have a positive return on investment based on that calculation. Okay, so we're going to climb back out of the rabbit hole. So finding Nemo, finding costs. Where can we get a hold of these costs? So direct costs are probably the easiest thing for us to get a hold of. And that is by working with your fiscal and budgeting staff that can break out the full position cost. And so that's not just the salary amount or the hourly rate, but it also includes the fringe amount. So what's the full salary cost? They can also help you figure out how much of the rent and utilities is your program responsible for in terms of, how much of the floor do they use, or however they want to allocate it as a percentage. You could also review your budgets that you've submitted to the state or to the feds to see what other costs you might have itemized. So this is really a line item way of doing the cost analysis. So, this might be a way to refresh your memory on what supplies you needed to buy to implement the program. Again, there's a limitation with the budget. As I said before, sometimes those budgets don't reflect our full costs, and that's usually the case with the personnel side of things. Indirect costs are a little bit more challenging to document. That we'd have to come up with an estimate of the market value. And I'll show some examples in terms of some of the tools, the worksheets you can use to set that up. But you see it oftentimes with the advocacy or voluntary organizations, sometimes brag about how many volunteer hours were donated to their efforts, whether that's the local food pantry or can't think of any other examples right now, but like the food pantry will say, we had 1,200 hours of time donated to us. And if we, they can apply different salary amounts or hourly amounts to those hours, and they can either, rank it low if they had a bunch of, high school students that were volunteering, apply maybe minimum wage to that, or they could apply a much higher salary amount if it's a bunch of professionals that were volunteering their hours. And probably the best practice is to come somewhere in the middle and come up with an average salary to estimate that market value of those in-kind contributions. And same thing's true for other, if they're material contributions. The averted costs are a little more complex to find, and here we'd probably go to the literature to see how likely is a condition to be averted, in terms of treatment costs. The absenteeism is a little easier to document, especially in working with an employer. But again, sometimes the literature can give estimates of how much as a percentage absenteeism was reduced. And then state Medicaid staff might be able to come up with an estimate of what their actual treatment costs are in terms of what are their reimbursement rates. So here's the last part of it, and I see we've got about 12 minutes left. So why don't we hold off questions until we run through this piece of it, and then there should be some time left to ask some questions. So here's kind of the nuts and bolts of how do you document the costs, and I'll talk about 4 more steps here: personnel costs, direct costs, indirect costs, and the averted costs that we can document. Here's an example of how we might set up a spreadsheet to document the costs. So you would want to list either broadly or generically what the positions are that are being used here in the left-hand column. The next column, labeled A, is the number of people in that position. Then column B, in parentheses, we have an average position cost. And so again, this is full position cost, which is the salary or wages plus any benefits that we might pay. Column C is the percent FTE on the project. And then the last column simply multiplies those 3 columns together to come up with the annual cost. So the first example here is, say we use health coaches that are throughout our community, and we have an average salary for those coaches at $48,000. And the average allows you, maybe some are paid $40,000 and some are paid $56,000, but on average, we're just gonna use that and call it close enough. We have 12 of these people, but they don't just work on our particular project. Maybe they're not only working on diabetes, but they're also working on smoking cessation, but we only wanna know the portion that they're working on diabetes prevention, and we're going to estimate that as 25% of their time. And then those three columns get multiplied together to come up with the 144,000. Another way to do it is to actually itemize by individual on your team that's implementing the project and come up with their exact position cost, again, their FTE on the project to come up with the annual cost. And then you would just keep listing every individual that works on a project, including members of your fiscal team, for example, if they provide support and their contribution to the project or their time on the project might only be 5% of FTE, but you'd want to make sure that you capture that so that it's as complete as possible. And you could also set it up similarly with hourly staff. You could either set this up as the number of hours or number of individuals, either use an average salary or the number of hours that they work to come up with the annual cost. So I think the personnel cost one is pretty straightforward about how we document it. But I think the indirect or portion, or not, I misspoke there, the non-personnel side of it, so the supplies and operations side gets a little bit more complicated, where we have to really think through, and again, this is where our budgets to the funder might help us remember what items we actually need to implement our program. And we would go through and itemize what type of office equipment, the number of the equipment, the cost per unit, and then again, multiplying A and B together to come up with the total cost of that equipment. We might be using brochures, for example, and initially we might think, you know, they only cost 10 cents each. Is that even worth capturing? Well, if we're giving out 200,000, then yes, it would, because in large numbers, suddenly those 10-cent brochures are having a $20,000 budget impact on us. You know, if we're talking smoking cessation, we might be making nicotine replacement therapy available for free, and we give out 6,000 boxes per year. Each one of those boxes costs $25, and it costs our program $150,000 to provide those free patches. And you can go on through if there's travel that's required to implement the project, if it's just mileage or hotel or both, and come up with the total cost over the course of the year. If there's training that staff need to go through, you'd want to capture that. So again, this is not an exhaustive list of what kind of additional operational costs might be incurred, but just something to get us started in terms of thinking about it. So here's actually a concrete example. Some years ago, our state oral health program approached me to say, can we figure out what our costs are for our fluoride varnish program? Partly because we were no longer going to receive the federal funding for it, and we needed to see what it would take for another agency, maybe state Medicaid or even the foundation world, to take over the project. We wanted to make sure that we had a complete accounting of what it might cost beyond just the 1 or 2 FTE that were actually implementing the program, going out to schools and putting the fluoride varnish on the teeth. So we set up this spreadsheet here, and here's just a snapshot of it that listed the different types of supplies that were required, including things like AA batteries for the pen light and replacement batteries, and then what the cost was per item, how many were in a package, potentially, how many were used per procedure or per day, to come up with the exact unit cost. And you can see some of these are such tiny amounts, but we wanted to make this pretty broadly covered so that we could say that per person, it costs us X amount of dollars in terms of supplies on top of the personnel costs. And then we looked at that as a way to see what would the Medicaid reimbursement rate need to be. So the indirect costs, again, those costs borne by agencies outside of our own, contributed to our agencies. We can set up a similar spreadsheet to the personnel one or the operations one that I showed before, where we would want to itemize. So maybe computers are being donated to our program. We would want to track how many of those, what were they worth, and as in terms of annually. If we have volunteer time, we could do that as by position or by individuals. So in here, I made up some numbers that volunteer nurses had a higher market rate value than student volunteers, and then we could allocate, of the hours, how many of the hours that were listed here in column A were actually for our project, to come up with a project-related cost, because they might volunteer for other things in our local public health department as well. So to only capture the costs that we needed. Or clinic space is another form, like in working with our school-based health centers, sometimes the schools donated space for the clinics, but without that space, we wouldn't be able to have a school-based health center program. So you would want to also capture things like that, where that space is an essential requirement for making the program happen. The averted treatment costs are a little more complex, and again, not critical, but depends on the audience that we're speaking to. Whose perspective are we trying to answer these questions in? But we could set up a spreadsheet where we look at only. So in this case, we're making an assumption. This is could be set up for an employer that the employer has 1,000 employees. 10% of the employees have a diagnosis of diabetes, and what we try to quantify is for those with diabetes. So if we're trying to promote a diabetes self-management education program, for example, how many hospitalizations are related to having diabetes? So not all hospitalizations will be diabetes related. In this case, we can say that we were able to follow up with the insurance to find out that 2 hospitalizations had a diabetes related diagnosis. They cost $1,000 each, so it's 100% attributable, and the total cost was $2,000 for the year. We also saw that we had 200 visits to the doctor, but only 50% of those were for diabetes. Some other things may have been flu related or for other causes. So we're only using 50% of the value of the 200 times the 150 to come up with our diabetes related costs, and so forth. In the example I shared before, if we're talking tobacco cessation and we're trying to appeal to the individual about the costs, we could quantify the cost to the individual. So, again, a different lens. So I can, these are kind of 2 tables mashed together, 2 different concepts. What are the costs to the individual to show the individual how they could be avoiding these costs of purchasing cigarettes if they stopped smoking. So again, this is just an idea for some ways to organize the data capture. Main takeaways are set clear parameters, decide whose perspective, because that will decide whose costs we need to include, as well as whose costs will be averted down the line. Determine the level of accuracy. Is it good enough to come up with an estimate of what salaries we use, or roughly what our costs are in terms of supplies, or do we need to go through the detail of itemizing it by individual and by each piece of equipment? Consider doing a short-term audit. Audit sounds scary, but it could be just somebody keeping track for a week or a month. How much time are they spending on our project versus time spent on other projects? So we can come up with a rough estimate of what percent of FTE should be counted. And then remember, even small items can add up if we use a lot of them over time. So I'm going to stop right there, and I'm sure people have some questions.
There is a question regarding, there's a comment like, not sure how avoiding sick days isn't a benefit, question, comment. And then also, how does one figure their share of rent and utilities?
Yeah.
When a nonprofit?
So let me answer the tougher questions first. So yes, absolutely. I think the avoiding sick days is a benefit. It's an outcome of our intervention. It's just that in terms of the math of cost analysis, those are seen as a negative cost, so that it's reducing the actual cost of our intervention. It's just this kind of strange way that the economic analysis deals with it. But if it's easier to explain to employers to say, by investing the, $300 a person on diabetes self-management education, you're going to save $600 in terms of reduced sick days, that works as well.
And then how does one
The
figure
share.
the share of rent and utilities when a
Yeah,
nonprofit?
that's a little bit tricky. I think, again, it'd be working with your budget folks to say, if say we have 100 people in our, broader branch, 10% of those, 10 people work on diabetes prevention or diabetes management, and they can take a look at what does that 10% of the rent for that entire branch look like to come up with an estimate.
And then there was an attendee shared how they looked at social impact partnerships to pay for Results Act grant. That's a mouthful.
Mm-hmm.
But it appears that sometimes those who pay for the program don't save the dollars, but they are
Yes.
saved by someone else, society
Yep.
as a whole.
Yep.
So, they're just stating how this is problematic when trying to show benefit to Medicaid, for instance.
Absolutely, absolutely. And I really like the concept of some of these grants, and in some ways, unfortunately, I believe they won't have the intended impact in terms of sustainability of funding, because those that are incurring the cost to provide the programs are also not reaping the benefits. So, very good point. We've had a discussion here in Colorado where we try to convince private payers to contribute to our tobacco quit line, because we could, we ask actually what insurance they have, but we still don't charge participants. And they said, well, why would, if I'm Aetna, why would I want to pay for it if Renee is going to switch to Blue Cross Blue Shield next year? They're going to get the benefit of, Renee quitting tobacco. We, and eventually we're able to make the case that there was enough churn that maybe Renee got the benefit through Blue Cross Blue Shield, and now she's coming as a former smoker back to Aetna. Eventually they did agree, but that's again an example of where those that pay, depending on the timeline or even in terms of the payment structure, might not reap the benefits or the return on that investment.
Well, that is all of the questions that were submitted. Thank you so much, everyone, for participating in this webinar. And thank you, Karsten, for sharing all that wonderful information and your knowledge, your experience. So to our attendees, you will receive an email the next day on how to access the webinar's materials. And we sure hope you'll join us for the next live webinar in 2 weeks. And then please, as you're exiting, take a moment to complete the post survey to tell us what was helpful and what wasn't, and what you'd like to see more of. This concludes our webinar. Bye-bye.